And now our last speaker of this session is Caro Roten. She's going to talk to us about Proximo-Distal Interphalangeal Arthrodesis as a first-line treatment for severe contracture of the fifth finger, the key sites and the pitfalls to avoid.
Thank you for your introduction. My name is Caro Roten and I'm a junior resident in AZ Delta Hospital in Roeselare. Today we've heard some promising words about Proximo-Distal Interphalangeal Arthrodesis as a salvage procedure. But what if we do this procedure in patients who had never had Dupuytren surgery before? I have nothing to declare. And sometimes patients present to our clinic with a fixed flexion deformity of the fifth finger, resulting in a hook finger. And this can significantly interfere with their daily activities. Just try putting your hands in your pocket or putting on gloves, washing your face with a finger that is permanently bent. And traditionally, we rely on fasciectomy and, in more severe cases, dermofasciectomy and skin grafting. However, the functional gain is often modest and the recurrence rates in the fifth digit are rather high. And that's when we turn to multiple surgeries, so revision surgeries, but this can lead to complications like nerve damage, infections, joint stiffness, etc. And after 3 or 4 surgeries, patients come to us with a wish to just remove the finger altogether. And that's when we normally do the salvage procedures or amputation. And as I said, this technique was introduced as an alternative for amputation because the fingertip complex is preserved as well as the fingertip sensation and the ulnar stability of grip. And moreover, it avoids the recurrence of the hook finger in the future. And we did the salvage procedure in the past, and our patients were very satisfied with it. And oftentimes people came to us and said, well, if I had known this, I would have done this right from the get-go. And that's when we thought, why can't we do this right off the bat, instead just as a salvage procedure? And then this is a surgical technique we use. We do a dorsal H approach over the middle phalanx, and then we do a sharp excision of the P2. Afterwards, we decorticate the head of P1 and the basis of P3. And then the reduction is done with an intramedullary K-wire. Take care not to damage the flexor tendon or the neurovascular bundle when doing the sharp excision. And here you will see the reduction with the intramedullary K-wire. And afterwards, we do a headless compression screw as well. And then because we shortened the finger, there is some excessive skin, so we resect it. Sometimes we do a limited fasciectomy of the pretendinous cord and or the abductor cord. And we did a number of cases in the past 4 or 5 years, and this is what we've learned so far. The first thing is to customize the dorsal skin resection. This is better for cosmesis, but better for skin healing as well. And when you do this, it's important to resect distally to avoid compromising the vascularity of the finger. Second is to don't undermine between incisions, so avoid dissecting too palmar, and if you do a combined volar aponeurectomy, don't connect the dorsal with the dorsal incision, because this can cause digital neurovascular bundle damage and venous congestion. We use headless compression screws, and preoperatively, before choosing our screw, we measure the diaphyseal canal diameter and adequate screw size in combination with adequate screw length prevents toggling of the screw. You don't need to do an extensive aponeurectomy. This only causes unnecessary soft tissue damage. We only do the pretendinous cord and abductor cord, as I said. And we use the compression screws instead of K-wires because it's immediately stable. So this allows for early active exercises and intensive physiotherapy, as Professor Goubot just said in his presentation. The early active exercises right from the get-go allows for faster functional recovery and less stiffness of the finger. And then this is our own series that we did. We had 12 patients, which we followed for more than 1 year. And the results were quite encouraging. So the range of motion of these patients was very good. We had full extension in all but one patient. And the MCP flexion, the mean MCP flexion was 100 degrees, which is more than enough for an MCP joint. There was residual abduction in 2 of our patients, but this was clinically not very important. We had 1 disease progression and 1 recurrence after 1 year, I guess it was, and no CRPS. But most importantly, patients were highly satisfied with this procedure. And these are my take-home messages. So we encourage you to not just only see this as a salvage procedure, but to consider this as your first step in the right patient, because it allows for faster functional recovery and patients experience less pain because it's immediately stable. It stays important to always inform about recurrence rate. This can either be palmar or in other digits. And the surgical mantra we use is to plan the screw, customize the skin, respect soft tissues, and move early. And then these are 2 examples of patients. They don't play. Yeah, thank you.
Thank you. Are there any questions from the audience? I think we are exhausted with all those P2 resections.
Why not a dorsal longitudinal incision instead of the H incision? For a normal arthrodesis, just not enough exposure.
No, yeah, that's right what you say. That's right. That's because just of the problem of the enormous, tremendous amount of skin you have in supplement. You take the flap that from Teboul, that is a kind of Houston flap, you could call it, or you take the 2 Proximo-Distal flaps. That makes it easier afterwards. What I have to tell is be careful about removing the flaps when you use the Proximo-Distal flaps, because I mean you only have 1 millimeter too deep, and you get problems with the vascularity of your finger. I've had 1 case, and I don't do it anymore because, on the end, it is shrinking, and eventually, with some silicone compression, you get a very nice morphology. I think, both techniques are really good, whether you remove without arthrodesis or with arthrodesis. People are so happy they have eventually an extension again of that little small bastard. Okay, I think we can adjourn this session. I would like to thank the speakers for their contribution and thank the audience for their contribution too. Thank you.